Right, so I would like to start very briefly with something that you might find interesting or not, but very often people ask me, what should I use in terms of stethoscope? And I can tell you that I have a stethoscope which is 35 plus years old, and I had it since I was a new grad, and I only changed the membrane because it broke after a while, and the earpieces. So my advice is get one and get used to it. Get used to it because that will be your companion for the rest of your career. And do you use this type of technology, the one when you got the diaphragm on one side and the bell on the other side, and then you twist? Actually, that's what I use. I use this model here. And how often do you use the bell of the stethoscope? You see, it's actually very important to get used to it. So use the diaphragm to detect the high-pitched sounds, and then use the bell to listen to the low-pitched sounds. So if we talk about respiratory sounds, then the high-pitched sounds are like stridors, stertors, this type, and loud ronchi, while crackles perhaps can be heard better with the bell. When it comes to hard sounds, perhaps the bell is better for soft sounds like in mitral regurgitation, and the diaphragm works better for the obstructions. But regardless, get used to try both. Try the diaphragm, twist, and try the bell. Okay, it takes a little bit longer if you try both sides, but it's important because one sometimes gives better results than the other. So let's get used to it, because I noticed that even in our team sometimes, because we're in a hurry, we don't actually pay attention to twist from bell to diaphragm. Or you can perhaps use this technology here, which is something that I don't really like. It's called the tunable technology. They are more expensive stethoscopes, and they're designed primarily for people, because the idea is that you apply the diaphragm to the skin, and then if you press a little bit harder, you can hear the high-pitched sounds. If you relieve the pressure a little bit, you hear the low-pitched sounds. Why do I say that they don't work well in our animals? Because we got a hair that, I mean, even people have chesty hair sometimes, but the idea is that when you got good contact with the skin, this works okay. If you have hair in between, not so much. So we do have one somewhere in cardiology downstairs, but we don't use it very often. Or you can have this one. If you're very rich, you can buy this expensive one, which is a tunable technology, but with two different sizes of the diaphragms. You can have a pediatric version, the pediatric side, which is the smaller one, and the adult one. But usually you see these stethoscopes in human hospitals when you got the cardiologist going to see children and adults at the same time. And then we got the double versus single tubing. I personally never tried the double tubing. Some people swear that they are much better. But as I said before, once you got your ideal stethoscope, keep it and use it, because you need to become very familiar with that one. And then we got digital stethoscopes. This is an old one in this picture. We got better ones now. The advantage of these ones, you can record the sounds, and that's what I'm going to play tonight. I'm going to play these sounds because I use this stethoscope here. But for everyday usage, I'm not sure it's a good idea, because it is true that they amplify the sound quite nicely, but they also amplify the background noise. So again, personal choice. Right, let's move to chest auscultation. And although the title is about heart murmurs, I'm going to talk a little bit about respiratory sounds as well, because there is a little bit of controversy, a little bit confusion. So we'll try to clarify, if I can, these little issues. But I always like this slide because it reminds me a Spanish colleague, a Spanish cardiologist called Oriol Domenech. And BSAVA many years ago, he started with a similar slide, and he said there are two types of auscultation. One is the clinical auscultation, where you try to focus, you close your eyes, you try to isolate from the surrounding environment in order to obtain the most, the best information from your auscultation. And the other one is called the social auscultation. So you got the clinical auscultation on one side and the social auscultation. In other words, you got 1, 2, 3 clients in the room, sometimes during the summer holidays. You got all the children that arrive with the owner, and they start talking. What do? We like them. We like it, so we give them the stethoscope, try to listen to the heart of your puppy or your kitten or your dog, etc. And so after this, we obtain zero information from a clinical point of view. We create a nice bond with our clients, but in terms of clinical information, not ideal. So we should probably try to be more on the right side of the screen and do more clinical auscultation than social auscultation. Right, so I'd like to start, as I said before, with the respiratory sounds, because as I said, there is a little consensus in terms of definition, and so I'm trying to clarify this. So when we auscultate the respiratory system, we start from the larynx and trachea. Very easy. We place the stethoscope, usually the diaphragm, on the level of the first tracheal rings, and we hear this blowing sound in inspiration and expiration. Is continuous, with the inspiration slightly longer than the expiration. And you need to pay attention to this, because when we have conditions like laryngeal paralysis, that difference becomes even bigger. So the inspiration can be much longer than the expiration. But otherwise, the inspiration is slightly longer, but overall similar. So what's the purpose of auscultating the larynx and trachea? As I said, you can hear stridors or clicks that can be associated with the collapse of the airways, collapse of the larynx, paralysis of the larynx, collapse of the trachea, and that can be very informative. But at the same time, I use this to count the breathing rate when I struggle to see the chest movements. Sometimes they're obese patients, and you really struggle to see the expansion of the chest, the excursion of the chest wall, and therefore that can be another reason for auscultating this organ. When it comes to lung auscultation, we don't really have specific points to place the stethoscope. So we need to try to imagine a triangle like this with one apex towards in correspondence of the elbow, and that's pretty much the extension of the lung fields. So what do? We place the stethoscope, and usually we start with the diaphragm, and then we wait for a couple of breaths, and then we move to another point, and then another point. So let's try to listen to ventral parts, and then dorsal part, cranial parts, and so on. And in normal dogs and normal cats, the lungs give a sound that's called vesicular sound. It's so soft that it's extremely difficult to record it. So I've got one recording here, but we need to pay attention in order to appreciate how gentle and low pitched this sound is. Could you hear it? Good. Could you hear it? That's more difficult, isn't it? Yeah. Anyway, that is a normal lung sound. Now, if we move the stethoscope, this is probably a little bit misleading, not exactly in this position, but more at the level of the thoracic inlet, we can hear the so-called bronchovesicular sound, which is a mixture of bronchial sound and vesicular sound. That's definitely easier to auscultate. The other problem we have when we record the respiratory sounds is the heartbeat, because it's not convenient to stop it, right? So we want to leave the heartbeat there. And therefore we got this continuous background noise that is disturbing a little bit, but we can't do anything. We could, but it's not convenient, as I said. Vice versa with the hard sounds, we can stop the breathing for a few seconds in order to eliminate the interference of the breathing sounds. Right, okay, now we're moving to the abnormal respiratory sound. Some can be heard with a stethoscope, some can be heard without stethoscope. And I don't know if you're familiar with this terminology or whether some terms are not particularly familiar with, you're not familiar with some terms like ronchi. Ronchi, for example, is a term that is officially used by the human terminology in respiratory sound. And this is the sound of fluidish material moving in the airways. So think about bronchial lumen with mucus. Mucus that is not too thick, but is quite fluidish and can move with the airflow. This will create a sound of big bubbles, I used to call it. And this gurgling sound is very indicative of an airway problem, like chronic bronchitis is the classical example. When you got chronic bronchitis, by definition, you have an excessive production of mucus, which is also tends to stagnate because of dysfunction of the mucociliary escalator. So this mucus stagnates and moves with the airflow, giving these big bubbles. And very often, I hear people calling this sound crackles. Crackles are different. They're much finer sounds, softer, and you can compare the sound of crackles with the sound of a Velcro strap. When you open it, you get that sound. That's what crackles sound like. And I've got two examples. I've got one with a very slow breathing rate and one with a faster breathing rate. Compared to this one, can you appreciate it's a completely different sound? Much finer, much softer. And I've got here one at a slower breathing rate. It's not much slower. Anyway, I hope it's clear, right? And we're going to talk about the genesis of crackles in a minute. Wheezes are whistles that are heard, particularly in the periphery of the lung fields. And they are typically associated with a narrowing of the airways, like in bronchospasm. Think about a cat with asthma. Okay, when they've got this narrowing of the lumen, then you can have these whistles. Another possible explanation would be parenchymal disease, like in pneumonia, or lung consolidation, like in a lung tumor. That's where we can hear the whistles, these wheezes. Now, crackles, I said, I was going to explain the genesis. We've all been taught that crackles are a sign of fluid in the lungs, also called the wet lungs. I'm afraid that's a very old concept and a very important misconception, because crackles actually generate from the collapse of small airways. When I say small airways, I mean bronchioles and respiratory bronchioles. And then they open with a subsequent inspiration in a very rapid sequence. We got thousands, millions of these airways that will suddenly open all in rapid sequence, and that gives that Velcro sound because they open with this popping sound. Associated not with fluid in the lungs, but associated with parenchymal disease. And actually, the best crackles you can ever hear, like those I recorded here, are lung fibrosis, coming from lung fibrosis, especially in the terriers. You know, I'm sure you've seen many of those. Westies and Cairn terriers, they tend to have predisposition to lung fibrosis. Because of the consolidation of the lung parenchyma, you got this problem here. But you can hear crackles also with pneumonia or neoplasia of the parenchyma. Now we got also the possibility of mixed sounds, like I've got one here that I record in a dog, where you can hear wheezes and ronchi together. Could you appreciate? A little bit subtle, but yeah, ronchi and wheezes together. Now, all the other sounds can be heard without stethoscope. They're quite loud, and we start with stridors. Stridors are like a very loud snoring or roaring, and that's due to upper airway obstruction, inevitably. Whether it is nasal or laryngeal, the sound is quite loud and like this. Certainly, we don't need a stethoscope for this. Usually they come through the door and they say, well, that's stridors, that's got airway obstruction. But again, some clinicians often get confused between stridors and stertors. They sound similar, but they are different meanings. Stertors are reported as sound coming from airway obstruction, but that's not entirely correct. It's primarily a gurgling sound coming from the pharynx, usually associated with dysphagia. So we got accumulation of saliva in the pharynx, and the airflow will create these big bubbles. And I've got a nice recording here. It's like stridors, but they sound wet stridors, if you know what I mean, because of this movement of saliva in the pharynx. And then you've got the reverse sneezing. Reverse sneezing is, again, an airway obstruction, but this time caused by the entrapment of the soft palate dorsally against the choane. It's a completely benign condition, self-resolving, and you can teach your clients to stop these reverse sneezing simply by closing the nostrils or promoting swallowing, because either by closing the nostrils or inducing swallowing, you create a negative pressure in the pharynx that will reposition the palate in the right place. And it's very important to recognize it, because these cases don't need any particular investigation. It is reported as a problem associated with nasal mites in some American states, but I'm not aware of a similar etiology here, at least in Europe. It solved. It barked, that repositioned the palate, and the reverse sneezing resolved. That also explains the importance of video recording, which I always recommend when they come and they talk about breathing, strange breathing sounds. Ask your clients to record the event, because this case here was going to be referred as a chronic cough. And when I saw the video, I said, you don't really need me here. You just have a completely normal dog. And they were very happy with it. Right, I've got other examples, but I can move to these two publications just to prove that crackles are not associated with pulmonary edema. And this is a study was published many years ago. And it's a study where they use excised canine lungs to reproduce the abnormal respiratory sounds. And the only explanation they had for crackles was that they're caused by opening of peripheral airways and not generated by sudden inflation of groups of alveoli. That's from excised canine lungs, and there's a study from human medicine where, again, they said that crackles The mechanism of Cracos is the sudden airway closing during expiration and sudden airway reopening during inspiration. So the story, this beautiful story of the gurgling sound coming from wet lungs is, I'm afraid, misleading information. And there is also a physiological explanation that this not can be true, because the pressure gradient that we have at the level of the small bronchi and bronchioles is approximately 3 to 4 centimeters of water. That force is not enough to move any liquid, can only move air. So at that level, we cannot generate bubbles. Okay, so what we hear when we got a dog coming with pulmonary edema is silence, is the beauty of silence, right? So you listen to the lungs and say, I can't hear the vesicular sounds. And that's because the fluid is sort of masking the normal movement of air. Okay, so the Cracos, if we hear Cracos, either parenchymal disease or perhaps we call Cracos what indeed are rhonchi. Okay? Now let's move to the heart, because we're here to talk about murmurs, but I thought it was a good idea to also introduce a bit of respiratory sounds. And so the heart auscultation nowadays is done with a stethoscope. But I remember when I was a student, just to show my age, when I was a young student, I was taught in large animals, not in dogs and cats, but with cows and horses to play. You did it too, because I'm not the only one. I remember they had at the university a very nice cotton sheet, so you don't have to place your ear directly to the skin of the animal, and then you were taught to listen to the sounds with your ear. And that's what they were doing in people too. And René Laennec, in 1816, invented the stethoscope because it was, according to what is written online, because that's where I read this story, he was a very shy guy, and he was so concerned of placing his ear on the chest of a lady. So invented this instrument to have no physical contact with the female patients. And then obviously the stethoscope started as a normal tube, and then it became a wooden type of amplifying system, and then nowadays we got the modern stethoscopes. Now I prepared this slide deliberately in black and white, so it looks very boring, because that's what they show us in textbooks. The points of auscultation, where we got on the left side the point of auscultation for the pulmonic valve, pretty much behind the elbow, and then dorsally and slightly caudally the aorta, and then dorsally and ventrally towards the sternum, the mitral valve, and then the tricuspid valve on the other side. This is okay if we are auscultating a horse or a cow, or maybe a giant dog, like a gigantic Great Dane or an Irish Wolfhound. But for all the other patients, when I place my stethoscope, I cover 2 or more of these points with my stethoscope. So we came out with a different terminology, where on the left side, we've got the yellow bit here, which is the base of the heart, where we got the emergence of the 2 big arteries, so aorta and pulmonary artery, and then we got the mitral valve more sternum. But again, that's in sort of middle-sized dogs. When we move to a Chihuahua, right, I think that differentiate between base and apex is slightly challenging. But certainly you need to remember this point, which looks like above the skin, but is actually under the left axilla. So when we auscultate a dog or a cat, especially when they're young, so young kittens and young puppies, make sure you go very well under the axilla with your stethoscope, because that's the point where we hear the continuous murmur of PDA. And PDAs are often missed, and sometimes we see PDAs here that then we close surgically or with interventional procedures, perhaps because the stethoscope was not placed high enough under the axilla. And if you miss that point, you may miss the continuous murmur. You may hear the systolic component, but not the continuous murmur. On the right side, yeah, we can leave that still as tricuspid point of auscultation. Right, so Let's move to the heart sounds before moving to the murmurs, because the murmurs are somewhat associated with the heart sounds. And we got two sounds that are systolic and two sounds that are diastolic. The first sound that we call S1 or a lub is caused by the closure of the mitral and tricuspid valve, almost simultaneously. So we hear one sound, although there are actually two components. And that's the early systole. But then in late systole, when the blood is being ejected in the pulmonary artery in the aorta, then the semilunar valves close. When the aortic valve and the pulmonary valve close almost simultaneously, then we have the second sound, S2 or dub. So we've got lub-dub, lub-dub, lub-dub. So the closure of these four valves are the cause of the systolic sounds. But then we have diastolic sounds as well. The first one is called S3 and is caused by the distension of the ventricular wall in early diastole when the ventricles fill. So basically the distension is like this type of sound, the distension of the ventricular wall. And then in late diastole, we got the atrial contraction, so there is an additional distension of the ventricle, which is S4. Now, in normal circumstances, we don't hear them. When I say normal circumstances, I mean in a dog or in a cat. If you do a horse, it's different because the heart rate is much slower. But in a dog and in a cat, because of the heart rate much higher, we struggle. And we struggle because our hearing keeps adapting to the loudness of the sound in the environment. And I always use the example of going to a nightclub. And when I was young, I loved to go to nightclubs. Now I'm too old. But maybe Sergio still goes to nightclubs. I don't know. Are you still going? You went Saturday. There we go. So Sergio can tell us his experience with the sounds. And then you spend the entire night, by these very loud speakers. And then you leave the nightclub and you start talking to your friends. You can't hear each other. Why? Because the eardrums is going into sort of a self-defensive mechanism. So it increases the threshold quite dramatically. So in order to protect you from the high sounds, you lose the soft sounds. And then we'll readapt, of course. Because S3 and S4 come after a loud sound, which is S1 and S2, we don't hear it. But when we have a third-degree AV block, so we got this bradycardia, if you pay attention, you can hear the atrial contraction so clearly in a dog that is pretty amazing. So you see bum, 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 which is the atrial contraction. Ladab, bum, 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 ladab, bum, 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 ladab. And I've got recordings here. If you have time at the end, we can play them. Right, so that is the explanation of the soft diastolic sounds. Right, we got two examples in dogs here. A slow, normal systolic, slow rate, lub-dub. Irregularly irregular because it's typical sinus arrhythmia. But when it gets a little bit faster, then it becomes much more regular. But we can still recognize quite nicely S1 and S2, or lub-dub. Now, diastolic sounds come, of course, in diastole, and S3, as I said, is the ventricular early relaxation. S4 is due to the atrial contraction, although the sound comes from the additional relaxation of the ventricle, not the actual atrial wall. And as I said, we struggle to hear them. But if there is a myocardial disease, the myocardial, the wall of the ventricle becomes a little bit stiffer, and therefore these sounds are amplified. It's also true that we got the same issue when there is an increased sympathetic tone, stress, anxiety, etc. can cause the same. But every time we hear these additional sounds, first thing we need to think is a myocardial disease. And because of the elevated heart rate, we can't really say, I can hear the S3 or I can hear the S4. We just hear an additional sound. And instead of being lab-dub, 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 we hear la-da-dub, 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 like a galloping horse. That's why we call it the gallop sound. And please, let's call it gallop sound, because in sound text we call it gallop rhythm, but it's not a rhythm, it's a sound. And I remember my mentor was going mad every time I was saying gallop rhythm. No, it's gallop sounds. And here we got a dog with a cardiomyopathy and typical gallop sound. Could you appreciate the three components? La-da-dub, la-da-dub, la-da-dub. Sometimes we get confused and we think, is this a gallop sound or we're dealing with split sounds? Now, S1 and S2 sometimes are split. You remember at the beginning I said the mitral and tricuspid valve, they close simultaneously. But there are some conditions, like in tricuspid valve dysplasia or with a right bundle branch block, where the tricuspid valve and the mitral valve close slightly at different times. And therefore, rather than having lab-dub, lab-dub, we got drab-dub, 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 because the first component is split in two. And this is actually a cat that had a tricuspid valve dysplasia. And you can see that there is a very clear split of S1. And then we got S2 coming after. I'm going to play for you. Yes, it sounds like a gallop, but if you pay attention, it's slightly different, because the first two components are much, much closer than in a gallop rhythm. But also we can have split S2. And split S2 is actually much more common than split S1. And that's when the pulmonic valve closes slightly before the aorta. And the typical example, the typical condition is pulmonary hypertension. And when we got a significant pulmonary hypertension, we hear this almost inevitably, because the pressure in the pulmonary arteries is higher than the pulmonary valve closes a little bit earlier, because it's the diastolic pressure in the big arteries that determines the closure of the semilunar valves. And on the phonocardiogram here, you can see very clearly the S1 and then the split S2. So this is actually a puppy, a young Irish setter with a reverse PDA. So it's instead of being right to left, left to right shunting, it's right to left shunting PDA. And that's because of the presence of pulmonary hypertension. You can hear the S2 is quite dirty. It's not a clear, sharp sound. It's lab-drab, 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 like this. And if you hear something like that, think about pulmonary hypertension straight away. And then we got atrial fibrillation. Now, probably you heard a lot of dogs and maybe some cats too with atrial fibrillation. It's completely chaotic, completely chaotic. And a few months ago, I was washing the surgical clogs in the washing machine, and I thought, that's atrial fibrillation. Identical, isn't it? So if you don't know how atrial fibrillation sounds like, that's it. It's like shoes in the washing machine. If you remember, we were talking about the social and clinical auscultation, which is absolutely true in dogs. When it comes to cats, even more so. Cats are very challenging for a variety of reasons. Fascinating animals, but when it comes to physical examination, can be challenging. And the major issue we have with cats is that approximately 2 out of 10, so 18%, start purring. Can you hear the heart? Can you hear the lungs? Nothing, right? So it means that 20% of the time approximately we have this issue and we can't hear anything. So believe it or not, we've done this study which is published. And you know, the typical congresses, you go with old friends, we start talking after a few beers, and you come out with this idea, why don't we do a study on how to stop cats purring? We did it. We did it. Right, and so what we did in this study, first of all, we tried to identify the prevalence, which is 18.2%, so pretty high, and then to identify the strategies that we can implement to stop a cat purring in order to auscultate at least the heart. And so what we did, we asked people in practice, and we said, can you give us your ideas how to do it? And we came out with 6 different methods. And in the first part of the study, we tested the 6 methods, and then we selected the 3 more successful ones. And the 3 more successful ones are blowing in the ear of the cat, spraying feely way, not at the cat, but in the room, so it's the sound of the spray. And then the third one is to run water through the tap, and then you hold the cat gently and with the stethoscope in position, and you walk towards this running water, approximately 1 meter away. And that's the most successful intervention. Okay, so the most successful intervention is the water. If that doesn't work, move to the aerosol. If the aerosol doesn't work, move to blow in the ear. We did try other methods, as you can see, the exposure to surgical spirit, they hate it, so please don't do it because it doesn't work. Touch the nose or squeak a toy. But I'll tell you something if we have time. In 1 minute, I can tell you this story. The reviewer was so pedantic that he said, you cannot standardize these techniques. So we're a group of friends said, let me reply. And I replied like this, like, run a tap. Hold the cat within 0.2 to 2 meters of a running tap. The tap should be running at the rate which could fill a cup of water in less than 10 seconds, but more than 2 seconds. And I wrote it as a joke for all of them. And guess what? The reviewer was happy. And now it's published. These things happen. But it was a real fun study. Remember the points of auscultation we mentioned in dogs? Even more limited in cats. In cats, if we hear a murmur, for example, and my trainees say, I can hear a murmur in a cat, I don't ask any more questions. I don't say, is it right, left, parasternal? No, because in cats, majority of murmurs, and we will see in a second from the results, come from the sternum, when you place the stethoscope on the sternum, which probably acts as an amplifier, as a rigid structure. And therefore, if we say sternal, left parasternal, right parasternal, absolutely fine. But the exception remains the PDA, where we need to go very deep under the axilla in order to hear the continuous sound. Now, we have already seen this, but this is a cat this time. Up to 200, 220 beats per minute is absolutely normal in a cat in a clinic. So sometimes it's also difficult to say which one is lub, which one is dub, because they're so close to each other. But then diastolic sounds are more common because cardiomyopathies are more common in cats than in dogs. And therefore, when the ventricle becomes stiffer because of the underlying disease, we hear the gallop. You may appreciate that there is a lot of respiratory interference here, but this was a Disney cat, so we couldn't really stop it. But yeah, so every time we hear a gallop sound, consider cardiomyopathy or an increased sympathetic stimulation. very stressed cats or dogs. But it's always a good idea to investigate because you don't want to miss a cardiomyopathy. Right, let's move to murmurs now, okay, since we have mentioned them. So what are murmurs? Murmurs are additional sounds. They're like whooshing or squishing sounds that come between the normal heart sounds. And when we hear a murmur, we should try to characterize them. And the characteristics of the murmur are the timing. Is it systolic, diastolic, or continuous? The location, if we can identify the point of maximum intensity. As I said, in a dog, we may say left base, left apex, or right, or under the axilla. In a cat, usually sternal or under the axilla. Radiation is something that is a little bit of, can cause a little bit of confusion, because radiation is when the murmur can be heard not on the other side of the chest, can be heard something like the neck or even the jaw. And a typical example is the aortic stenosis that can radiate to the neck. But if we hear a louder sound on the left and we can hear it on the right, we shouldn't actually call it radiation, because very often actually there are two different murmurs, one coming from the left and one coming from the right. Typical example, mitral valve disease. And in 90% of mitral valve disease, we have also tricuspid regurgitation. So it's not a real radiation, it's the two components. Intensity, we're going to simplify the matter with the intensity or the loudness of the murmur, because traditionally we use the Levine scale, which is 1 to 6, but I can show you can use a much easier scale that is also much easier to remember. Then the pitch, we have already mentioned the highness or lowness of the sound, and the quality. So we can say it's musical, it's blowing, it's harsh, and I've got examples to for convincing you. Now, the Levine scale is something we keep using because it's like an automatic pilot nowadays, but it's not very intuitive and it's not actually very accurate either. And it comes from human medicine, it's been adapted in veterinary medicine, and we got this scale from 1 to 6, where 1 is a murmur very difficult to appreciate. You need perhaps to spend 10, 20 seconds auscultating until you can hear it. And then you go grade 2, which is immediately audible, but the loudness is softer than the hard sounds. With grade 3, same loudness. Grade 4, louder than the hard sounds. And then grade 5 is nothing to do with the loudness. Grade 5 has to do with the vibration that you can appreciate with your hand when you place the hand on the left side of the chest. And grade 6 is when you can hear with the stethoscope away from the chest. You can lift the stethoscope a few millimeters away from the chest, it's still audible. But that again can be caused by a variety of different situations. I don't remember. Do you remember, guys? Emma, do you remember that dog that was walking? We could hear the murmur. I didn't even have a regurgitation. It was just a prolapse. Yeah. So that's why this additional grading is not particularly helpful. So a few years ago now, let's talk about more than 10 years ago, we published this paper where we tried to correlate the loudness of the murmur with the severity of the disease in mitral valve disease. And what we did, we tried to compare grade 1 with grade 2, 2 and 3, 3 and 4, and so on. And we found that there is no any difference in the clinical information that you obtain by using the Levine scale. So if you call these murmurs soft, moderate, and loud, you have exactly the same clinical information. And you can add, if you want, the thrill, the vibration. So here we try to plot the loudness of the murmur with the size of the left atrium, and you see that with the increased loudness of the sound, the left atrium is bigger, so it means that the disease is more severe. But this one is even better because you can, with a pretty good accuracy, you can predict what the underlying severity is. In other words, if you have a soft murmur, 90% of these dogs will have no cardiac remodeling. So if you have a soft murmur, yes, of course you can echo to make sure that you're dealing with a B1, but then it may not be necessary. Moderate, we got approximately 40% still in B1, another 50% that are in B2, so they start having cardiac remodeling, and then a very, very tiny, less than 10% of dogs that are in congestive heart failure. And then you see you move with with increased loudness, and you got increased severity. So that's what we can use very with a very easy approach, and is very relevant from a clinical point of view. Now, systolic murmurs are the majority of murmurs. So when you talk about timing, the majority of murmurs are in systole. And I remember my students when I was teaching at university, and I remember their faces, first murmur of their life. And I was going to say, is this systolic, diastolic, or continuous? Panic, panic. They didn't know what to say. I said, come on, just say systolic. 90% you'll be right. And then they were much happier after. So the other terminology that is used in textbook is this crescendo, decrescendo, or diamond-shaped murmur. It's almost impossible to appreciate this variation in loudness within the murmur itself, with the heart rates we have in our patients. So what I like to call it is harsh and musical, and I will show you the difference by playing sounds. So harsh systolic murmurs are caused by obstructions of the outflow tract, with either aortic obstruction or pulmonic obstruction. Now I play the sound. Now you try to close your eyes for a second and try to imagine a saw that is cutting a log. That's what I call a harsh sound. Does the analogy work? Yeah? Cutting the log. And it's true. If the heart rate is not too fast, we can, with probably 90% accuracy, say, we got an obstruction, rather than the other type of sound that is associated with the regurgitation. So all regurgitations, but also ventricular septal defects, they give a much more musical sound. So now we don't have the saw, it's like a flow of water. So if we hear a systolic murmur like this, and we try to identify this harsh or musical component, then we have already a good idea about the underlying condition. Systolic. Now, diastolic are very rare, very rare. In the study that we published recently in cats, less than 5%, so very, very few. And unfortunately, every time we got a diastolic sound, we don't have the electronic stethoscope available. So I never managed to record one. We had a beautiful one surgery a few months ago. Has that cat came back? No? No? You discharged it before we could record it. Yeah. Right. Black note in his book. But there are simulators. You can generate murmurs. So I generated this one with an electronic simulator. And you will realize that it's completely different diastolic sound because it comes at the wrong time. It's not like what we would expect. And the sound is more blowing rather than, it's more sucking rather than blowing because it sounds like this. Listen. If you hear a diastolic sound, you know that that's aortic regurgitation. Because pulmonary regurgitation, in theory, should give a diastolic sound, but we never hear it. Probably there is not enough energy to produce an audible diastolic sound. But continuous murmurs are slightly more common, almost inevitably associated with a patent ductus arteriosus, and we got the systolic component, immediately followed by a diastolic component. So we hear the murmur with no stop. Remember to go very up under the left axilla to hear this one. And if you hear this sound and simultaneously you can perceive bounding femoral pulses, you got 99.9% of your diagnosis. Okay, so that's a PDA that most likely needs to be occluded or ligated. So as I said before, we worked a lot on heart murmurs in cats. So from now on, I will focus attention primarily in cats. And we examined approximately 1,000 clinical records, so 856 of cats with murmurs. The novelty of this study is that we try to identify the source of the murmur. In other words, to identify the turbulence on echocardiography that is responsible for the heart murmur. And all the previous studies that have been published didn't look at it. They were finding murmurs and say, caused by HCM, hypertrophic cardiomyopathy. Or hypertrophic cardiomyopathy does not explain why you have a murmur. And indeed, you don't have all cats with HCM with a murmur. So that's the big novelty. And also, I'm going to show you the importance of iatrogenic murmurs. So there's, for example, a study that comes from the Royal Veterinary College, a great study, very well designed. And what they did, they tried to correlate the presence of the murmur with the thickness of the left ventricle. And funnily enough, they didn't find any association, because it's not the thickness of the ventricle that causes the murmur, right? So that was the little pitfall of this study. But important to show that at least the hypertrophy is not associated with that. And one thing I forgot to say, this paper here, if you want, is available online for free. You can download it if you're interested, and you can download it from internet. Right, so you remember this classification. We avoided that in this study, and again, we combined 1 and 2 as soft, 3 as moderate, and the other as loud. Much easier, no? And we found that the majority of murmurs in cats are actually soft, followed by moderate, and loud only 12%, and palpable murmurs when you can actually feel the thrill in a very, very small percentage. But one thing that we find in cats quite often is the presence of dynamic murmurs. Dynamic murmurs change in loudness, and sometimes it's 2, then it becomes 3, or soft and then it becomes moderate, moderate then it becomes soft again. Or it's typical when you listen and say, oh, there is quite a loud murmur, and then you pass it to your colleague and say, oh, it's not loud, it's soft. So yeah, there is subjectivity, of course, but also the murmurs can change. And actually 27% means approximately 1 in 3. Approximately 1 in 3 is a dynamic murmur. So it changes in loudness. And this change can be associated with a heart rate, but not necessarily. Point of maximum intensity here with trying to differentiate between the different areas, we found that the majority are sternal. Sternal, right parasternal, left parasternal, and only a few are being 1.7% have been clearly classified as left base or left apex. Okay, all the others are sternal, right parasternal, left parasternal, so always there. In terms of timing, the majority are systolic. And the two, we're going to see the causes, the two major causes, but certainly systolic anterior motion of the mitral valve is one of them. I just briefly play the sound of a cat with systolic anterior motion. She's a bit harsh, dynamic obstruction, or a VSD, more musical. So even in cats, we can do the same. As I said, diastolic, that's artificial, so I don't have a real diastolic in a cat. But I do have this cat with a PDA. And again, sounds like that machinery sound that we hear in dogs. And it's true, cats don't have PDA as often as dogs, but we do see a handful every year, 4 or 5 cats with PDA, so something that we need to bear in mind. Remember what I said earlier? Always under the axilla. There's a phonocardiogram of this kitten with a PDA under the axilla, continuous murmur. But if I move the stethoscope away more towards the sternum, I lose the diastolic component, and I can only hear the systolic component of that PDA. So we need to be careful, making sure that we place the stethoscope quite high. Now, if we want to be very pedantic, right, we can also differentiate between continuous and to and fro. To and fro murmurs are not common in dogs, but in cats, sometimes we see ventricular septal defects. So basically, we hear the two different components. We hear the systolic component through the VSD and the diastolic component coming from the aortic regurgitation. It's not a good recording. Right. Remember when I said timing, when I was telling the students, say systolic all the time. It's true, even in cats, 90% of murmurs are systolic. We got 5% diastolic, 4% continuous, and 1% to and fro, which means we had less than 10 cats in that study with a to and fro murmur. But let's look at the most common causes of murmurs in cats. And in terms of etiology, we have acquired condition 30% of the times, congenital defects 13% of the times, but I think that's the real cool thing. 55.9, they have no heart disease. So more than 50% of murmurs in cats are not associated with any cardiac condition. We got explanation for that, we're going to see it in a minute. But let's look at the actual genesis. Where is the turbulence coming from? 40% approximately is a systolic anterior motion of the mitral valve, followed by dynamic right ventricular flow obstruction, and then we got a so-called flow murmur, mitral tricuspid regurgitation associated with dysplasia, and then a number of congenital defects where, depending on the defect, the turbulence comes from different areas. But the big chunk is here. Dynamic obstructions on the left and the right. So what is systolic anterior motion? It's a fascinating condition, and still we don't know exactly why they have it, because it could be a deformation of the mitral valve architecture, associated or not with hypertrophy of the myocardium, could be hyperdynamic states, could be intrinsic valvular disease, and it is important to remember that it is not pathognomonic of HCM. And in the past, textbooks say if you got a systolic anterior motion, that's associated with HCM. We actually don't see that very often. We should probably do a new survey. I would probably say gut feeling, 7 out of 10. do not have hypertrophy. Anyway, what is it? It's an abnormal movement of the septal leaflets of the mitral valve. In systole, the two leaflets should just coalesce and close the communication between atrium and ventricle, and so the blood can go into the aorta with a nice laminar flow. But if for an abnormality, which can be any of those that I listed earlier, then we have an obstruction of the outflow tract. And when I try to explain this to my clients, I use the analogy of the garden hose, and I say, try to water, imagine to water your garden, you put a thumb at the end of the hose, you got the squirt of water, which is noisy and is caused by the turbulence of the water. In this case, the turbulence is blood. But they understand immediately what the condition is. And because the movement is in systole, then we got, for a fraction of a second at least, the free communication between atrium and ventricle, and therefore we got a degree of mitral regurgitation. So there are actually two components. And in these images here, you can see the two components. There's the left ventricle. There's the aorta going out. So we got the obstruction caused by this abnormal movement of the mitral valve, septal leaflet, and then we got a degree of mitral regurgitation. I also like to, well, we have a rule that we cannot call it sum unless we got three features on echocardiography. One is the double jet on color Doppler. One is this dagger shape of the aorta. This flow on Doppler should be very symmetrical, but because of this interference of the valvular leaflet, we got a sudden acceleration of the blood flow, and that's this step here. You see when the blood suddenly accelerates, and when we do an M mode of the mitral valve, we see this little bumping movement of the valve that for a fraction of a second starts flicking towards the interventricular septum. There are several hypotheses about the genesis, but probably the most convincing one is the excessive elongation or excessive length of the septal leaflet. And because it's so long, it goes and interferes with the outflow tract. And actually in this study, beautiful study from Carsten Schober from Ohio State University, he found that with increased length of the septal leaflets, we got increased degree of obstruction. So that's very convincing. So this is one of our cases here. This is a cat with hypertrophy, but you may appreciate how long is this leaflet that goes well inside the left ventricular lumen and causes this obstruction. But you can see it also without hypertrophy, like in this case. And this is actually a case of SAM caused by stress, not by pathology. And you can see the double jet without a real hypertrophy. When we have these cases, sometimes we hear the murmur, we start the echocardiogram, and we can't find anything. Because meanwhile, the cat has relaxed and the obstruction is no longer there. So I learned this trick from a pediatric cardiologist. And what he was doing with children with the same problem, he was gently increasing the loudness of the Doppler. So you got the outflow, and the sound is like shoo, 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 shoo. And then increase the volume. Shoo, shoo, shoo. If you do it through a cat, the heart rate starts going up. And so the catecholamines are working, and you may evoke an obstruction that wasn't there before. And that's a very beautiful example of increasing the loudness, and all of a sudden the obstruction becomes more and more visible. Is it ethical? Well, debatable, of course. But certainly if they're doing children, perhaps we can appreciate that is not too bad, isn't it? But at least you can identify this condition. In people, they take this condition very seriously because when there is a severe systolic anterior motion, it can be symptomatic to the point that can be very lethargic, they can faint, or they can even die due to the obstruction. So they try beta blockers first. If beta blockers don't work, then they may consider even surgery. So the septomyectomy, which is a surgical removal of the proximal part of the septum, is considered to open the outflow tract, or the alcoholization of the proximal part of the septum. In other words, you go with a small catheter inside the branch of the coronary artery and you inject alcohol. Alcohol will kill the cells, and then the fibrosis, the scarring that results from that, will retract the muscle at that level, and you open the tract. It's not very safe, okay? There are a lot of fatal outcomes, so probably not a very interesting thing, important thing to consider in our cats. But some I don't think is particularly benign, right? And you can see these images are quite dramatic. Because of the continuous contact of the septal leaflets with the septum, you have the so-called kissing lesion or contact lesion, which is a scar due to this continuous friction. And on histopathology, you can see the blue color is fibrotic tissue, so it's a scar, in correspondence of the contact between the anterior leaflet and the septum. You may notice that also the posterior mitral leaflet is bluish, and that's probably because of the shear stress caused by the mitral regurgitation, and therefore it can't be that benign. So we always try to keep an eye on these cases, even if they don't have evidence of hypertrophy. In this study from the RVC, they found that cats with some live longer than cats without some. Doesn't make any sense, does it? So we thought that perhaps the reason why we got this result is because if they got some, they got a murmur. So they get a much earlier diagnosis, and therefore the survival time is much longer because it's a very early diagnosis. But you know better than me that very often these cats present in over heart failure, right? With no history of heart disease before. So they had the underlying hypertrophy, the underlying disease, but not an audible murmur, so an echocardiography was never done. That's my interpretation. I think that it would be very unlikely for some to be a benign condition after what we saw on histopathology. So a while ago, we came to the conclusion, we started creating the hypothesis that perhaps the dynamic obstruction is the cause of hypertrophy and not vice versa. Because if you have an obstruction, you got increased pressure gradient, you got pressure overload in the left ventricle, which is a stimulus for hypertrophy. And so we try to understand whether is some causing pressure overload and hypertrophy, or whether it's the hypertrophy causing some. It's the chicken and egg story, isn't it? And the only way to solve this question is to use cats that do not have hypertrophy and follow them over time. We're still working on that. Actually, Sergio is one of Sergio's projects. But the other thing we wanted to look at is the biomarkers, because if the obstruction is so severe to cause hypertrophy, then the myocardium will suffer somehow, either by stretch or by damage. So if you got stretch of the myocardial fibers, we got increased NT-proBNP. If we got damage, we got increased troponin. So that's what we looked in these cases. And on the left side, we got the NT-proBNP. The yellow area here is the normal values. And you see they're all above, with the exception of 1, 2, 3, and 4 cases. So 4 cases were within normal, and these 4 cases had some that could only be evoked with a provocative testing. So it was just a sympathetic problem, a sympathetic stimulation. We didn't have troponin for all cats, but those that had troponin showed a degree of myocardial damage. So some cannot be that benign if it causes all these mess. And actually what we found we also found a linear correlation between the degree of obstruction and the level of NT-proBNP. So that's certainly a very important thing to consider. So that's for the sum. Now, the second most common cause is what we call Dr. Voto, which is dynamic right ventricular outflow obstruction. And that's heard in 1/3 of cats with a murmur. It's found in 1/3 of cats with a murmur. The pathophysiology is similar in a way, so it's a dynamic obstruction, but this time of the right outflow tract. So that's the right outflow tract, right ventricle opening into the pulmonary artery. And you see the turbulence here? And the dagger shape that's similar to the sum shape of the in the aorta, here is in the pulmonary artery, because we got a sudden acceleration of the blood flow in mid-systole. But over the years, we noticed that we may cause it ourselves. If we press with a probe of our ultrasound a little bit too much, we can create this obstruction here. And that's exactly what happens. That's what we call the provocative testing. We press gently with a probe of our ultrasound machine, and we move from a laminar flow to a turbulent flow. Because we narrow the lumen of the right ventricle in that point, and we cause the turbulence. Here, I've done it by pressing progressively and see the nice laminar flow that becomes turbulent and faster. And I did it myself. So it's not an intrinsic problem of this cat. And if you put a stethoscope and do the same, you press with a stethoscope, as soon as you start pressing on the right side of the chest, you may induce a murmur. That's just to show you how much we can increase the velocity there simply by pressing with a probe. We can move from approximately 1 meter per second in the pulmonary artery to 2 meters per second. And by moving from 1 to 2, the flow moves from laminar to turbulent, which means from no murmur to murmur. And one reviewer argued and said, perhaps because you're pressing, you're disturbing the cat, the heart rate goes up, so it's not actually the obstruction that you're causing, it's the heart rate that causes the... But when we did analysis and the correlation between the heart rate and the peak velocity measured on Doppler, there is no correlation at all. And to be honest, the movement is the pressure is so gentle that the cat doesn't even notice it. So what we did then, we moved to first opinion practice, and these 3 colleagues in first opinion, experienced clinicians, they were all certificate holders, they were trying to evoke the murmur just with the stethoscope in cats that were apparently healthy coming from annual vaccination. And they managed to induce the murmur in 28% of cats. So 1 in 3, nearly. So 1 in 3 cats, if we press a little bit too hard, we cause a murmur, okay? And obviously we're very happy because we were the first group to report it. Approximately 8% of cats with tricuspid regurgitation have a murmur. 8% of cats with mitral valve dysplasia have mitral regurgitation have a murmur. So this is the 3rd most common cause of heart murmur in cats, because these 2 congenital defects are quite common in these species. An example of mitral valve regurgitation on the left and tricuspid valve regurgitation on the right caused by dysplasia. Very common in cats. When we call it flow murmur or innocent murmur, we're not very convinced about that. The innocent murmur is something that is very well described in pediatric cardiology. And it's a murmur, usually very soft, and almost inevitably at the level of the outflow tract, so left base. And can change in loudness, although it's soft, can from 1 to 2, can change with body position, can change with heart rate. We don't actually do all these tests in our patients. And I think that perhaps flow murmurs in this study here was reserved for cases where we could not identify the source. And we believe that perhaps were iatrogenic murmurs, simply we didn't do the provocative testing properly. Okay, so that's at least my interpretation. And then the congenital defects, of course, cover all the other percentages. So if we look at the characteristics, if we have a loud, palpable or continuous or diastolic murmur, 100% inevitably associated with a congenital defect. So when we have a loud murmur in a cat, always a good idea to echo. But vice versa, we got a negative association between soft systolic murmurs or intermittent murmurs or murmurs with a point of maximum intensity of the right parasternal area, because they are probably iatrogenic murmurs. So we are nearly at the end. My suggestion is to consider an ultrasound every time you are in doubt, because that would be a definitive answer. But I appreciate that sometimes either there is no financial availability, or there is not the right equipment or the right expertise in the practice. So an alternative is to run NT-proBNP in these kittens, because NT-proBNP, if it comes back as normal, it means that that murmur is not causing any problem. I would say 99% accuracy. 100% in biology doesn't exist, so 99%. But the problem is that if it comes as high, you still need to echo. So actually you end up spending more than with the initial plan. So it's a little bit of a challenge, but something can certainly be discussed with your clients. And I would perhaps take the opportunity to let you know that perhaps if you're not aware, we have been running now for 5 years, 6 years? How many years? 5, 6 years, the puppy and kitten murmur clinic. So if a patient is less than 6 months, although there is a bit of flexibility, not much, but around that age, then we do a full echo examination for, I can't remember, £195 including VAT. So that's something. And the reason why we do it is because if they're diagnosed early, certain congenital defects can be fixed quite successfully. Talking about PDA, pulmonary stenosis, aortic stenosis less so, but we do have a good outcome with these interventions. The earlier the diagnosis, the better. The earlier the intervention, the better is the outcome.